Hello and welcome back to our video series on pediatric growth, development, and assessment. This is part 2 where we'll be focusing on the infant. Again, you can view these learning objectives on the PowerPoint that accompanies these videos. So the infant developmental age period is divided into two sections: the neonatal period, which is the first 28 days of life, and the infant period, which goes from the first month all the way up to they turn 1 year old. And now, there are very important physiologic reasons that we split these up. For example, if the neonate gets sick, it tends to be an illness that they caught from the mother, whereas if the infant gets sick, that tends to be more of a community-acquired illness. This first year of life is a period of rapid biologic development. Just in terms of proportional changes, while the infant may lose 10% of their body weight in the first week, they're going to gain that back fast. The infant should double their birth weight by 6 months old and triple their birth weight by 1 year old. And the parents will note that this growth typically comes in spurts. There are many important anatomic and physiological differences in infants than there are of toddlers or any other age group. As we talked about in part 1 of our series, their heads are proportionately larger than any other structures, making them very prone to head trauma. Their cranial sutures are not fused, therefore they have the fontanelles that are open. Their skin is thinner, they have a higher body surface area and less fat, so that they cannot thermoregulate as effectively. Their sebaceous glands are very active, causing baby acne, or what we call milia. And they're obligate nose breathers. So until they're 4 or 5 months old, the younger infant who has viral bronchiolitis, having some nasal obstruction from mucus is going to be a bigger deal to them than it would be to a 2-year-old. Going on to other differences, their airways are smaller. Their larynx is the most narrow portion of the airway. Their hypoxic and hypercapnic drives are not fully developed. So in the preterm infant especially, but also in the neonate, you may notice some periodic breathing. Their lungs are still developing. Their alveoli are not done differentiating and maturing yet. This can make them very prone to respiratory distress. They have a rounded abdomen due to weak musculature, and also lower esophageal sphincter tone, which means they can have reflux. They also have a higher relative blood volume and proportion of body fluid, which makes them at risk for dehydration. And as we all know, the younger they are, their humoral and cell-mediated immunity is not developed, so they're very prone to infection. And that's something that we take very seriously, especially in the first 28 days. Now, maturation of systems. They start off with a very high respiratory rate and a very high heart rate that begins to slow over that first year as things continue to develop, such as their alveoli. They also have important hematopoietic changes, such as physiologic anemia. Maternal hemoglobin does not stick around long enough for the infant to make their own hemoglobin, so we'll see a physiologic anemia. There's also important changes in other systems, such as the hepatic system, where we're not going to see effective synthesis and storage of glycogen, so the infant is more prone to hypoglycemia. We talked a little bit about immunologic immaturity already, and thermoregulation. Now, renal function is also not mature yet. Normal urine output is 1 to 2 mLs per kilo per hour. And here's just a picture to give you an example of how much things are changing just in the first couple years. And this is a look at inside the child's brain, and these are all neurons that are developing, myelinating as we go through the first 2 years of life. In that first year of life, we start to see some fine motor development. They should be able to grasp objects, first with their palms by ages 2 to 3 months, and then start transferring objects by about 7 months. They start to develop that pincer grasp, and they should have that down pretty well by 10 months. And then they'll be building towers of 2 blocks by about the first year of age. For gross motor development, we talked in the first video about head control. And you can see here in these pictures, there should be complete head lag at 1 month old, but by the time they get 4 months old, they really should have the musculature developed to keep their head up when they're being pulled up from their arms. The child who cannot do that raises concerns for neuromuscular disease. And again, predictably, they should be able to hit milestones such as rolling over from the abdomen to the back by 5 months and from their back to their abdomen by 6 months. You can see here in the picture the development of sitting, where 1 month old, you can see that they can't sit upright. At 2 months old, they have a little bit better control. And by the time they're 8 months old, as you can see in the final picture here, they should be able to sit up without much extra support. And a big change in the first year of life is the development of locomotion, which you can see here. Typically, they need to be able to bear weight when you assist them to stand up, and that happens by about 7 months old. And they can stand and hold on to furniture by about 9 months. They're taking their first steps by 10 months, and they're just crawling and creeping all around by 9 months old. For psychosocial development, the infant is, in terms of Erickson's stages, still developing a sense of trust. And that's why it's so important to promote bonding between both parents and the infant. This is done through feeding, play, and stimulation, and other ways of fulfilling the infant's needs. Cognitive development is also really noticeable in the first year of life. Major accomplishments during the first year of life: dealing with separation, starting to develop some object permanence. You'll see just primitive reflexes by birth to about 1 month. After that, we're going to see some circular reactions and then more application of their ability to learn, imitate, and change their behaviors to meet their needs and their natural curiosity about the environment. For social development, this is very much influenced by reflexive behavior. You'll start seeing separation anxiety slowly develop between 4 and 8 months old, and by 6 to 8 months old, stranger danger should be very prominent. Language development is also prominent. By 3 to 4 months old, the infant is cooing and laughing. By 6 months old, they're trying to imitate sounds and certain consonants and syllables. 9 to 10 months, they're starting to understand the meaning of words like no. And by 1 year old, they can actually say 3 to 5 words and have a meaning behind them. Now, while they can only say 3 to 5 words, they can understand all the way up to about 100 of them. Now, dental health is very important. Typically, the infant should see a pediatric dentist by about 6 months of age for their first fluoride application. And they can get dental caries at this age. That's why it's so important to not prop the bottle to help them go to sleep. Speaking of sleep, infants sleep a lot, and you can see in this table to your right that infants from birth to 6 weeks should sleep about 16 and a half hours a day. Now, by the end of the first year, that's down to 11 to 14 hours a day, which usually is comprised of a pretty good period of sleeping overnight with a couple naps during the day. Nutrition is also important. The first 6 months of life consists of human milk or formula. If the child is only breastfed, then you want to make sure that they're also being provided with an iron supplement. During the second 6 months of age, we start to introduce solid foods. These are typically purees, and they are introduced one food at a time. When you start to see your pediatric patients, performing a thorough review of systems and health history is extremely important. There's a great example of a comprehensive review of systems in the textbook provided here. And also, we want to make sure that we hit all of the components of a health history, such as prenatal care, birth and neonatal history, medicines, allergies, hospitalizations, any known medical problems or surgical history, screenings and immunizations, including their newborn screening that was sent to the state. Family medical history is important as well, especially with genetic disorders, and social history is important. We want to know who are the primary caregivers, what is the home environment like, what is the infant's temperament like, and all of this helps us provide a safety assessment for both the parents and the child. Anticipatory guidance for the infant should include separation and stranger fear. This is especially important for children, as you can see on the next line, who have to go to daycare. Setting limits and discipline, although it sounds strange, you need to start this early. Thumb sucking and the use of pacifiers. Teething, which starts most of the time around 6 to 10 months old and can be a very difficult process for both the child and the parent. Vaccination hesitancy and reactions, and safety, safety, safety. Make sure that they're using the right car seat. Make sure they have smoke alarms and CO2 detectors. And then another good example is positional plagiocephaly, which may be present from birth or if the infant particularly favors one side of their head, but it's important for parents to know that this will resolve. Another good topic for anticipatory guidance is colic. Colic is defined as paroxysmal abdominal pain and excessive crying, which usually consists of crying for several hours per day, more than 3 times per week. This happens in about 15 to 20% of all infants. There's many theories on what causes colic. Many of the current theories point to a suspected cow's milk allergy, but other potential etiologies include feeding too rapidly, overfeeding, swallowing excessive air, or improper feeding techniques. There's many ways that we can help parents deal with a colicky infant. If you really suspect a sensitivity to cow's milk, we have to do a period where the child receives no cow's milk protein, and if the child is breastfed, the mother also receives no protein whatsoever from milk. This includes yogurt and cheese and any other sources. Another good topic for anticipatory guidance is sudden infant death syndrome. There seems to be a genetic predisposition to SIDS, but we can always teach our parents. Make sure the child is placed on their back to sleep. Make sure there aren't a lot of fluffy blankets and toys in the crib. And make sure that we educate them. Now we're going to review a quick physical assessment of the infant. The sequence in which you perform this assessment is vital to your success. We typically teach you to go from least invasive to most invasive. And you can see here, we do some of these things the earliest because they're the most accurate when the child is calm and cool and collected. A great example of that is vital signs. The heart rate and the blood pressure will change drastically when the child wakes up and starts to cry. So following this recommendation, you'll do vital signs and do a general observation and listen, auscultate their heart, their lungs, and their abdomen prior to doing anything else. And this will get you the most accurate physical assessment. And there's a lot of things that we can tell about the infant without even having to touch them. The example given here is from pediatric emergency medicine, and it's called the pediatric assessment triangle. Without even touching the child, you can tell so much about their appearance, their posture, whether they are sleeping, their muscle tone. You can tell a lot about their circulation. Do they look pink? Do they look pale? Are they mottled or cyanotic? And also their work of breathing. Are they nasal flaring? Are they tachypnic? For the chest and heart, of course, we have to inspect the skin. We're going to be looking for respiratory rate, knowing that abdominal breathing and predominantly using the diaphragm at this age is normal. We also want to look at their chest shape. And we want to auscultate heart and lung sounds in all locations, including the back. For their abdomen, we're going to be looking for distension. A scaphoid appearance is concerning for diaphragmatic hernia. We also want to look at their umbilicus. Is it healing normally? Is there redness? Is there drainage? We'll listen to bowel sounds in all 4 quadrants, as well as palpate for any organomegaly. For the head and face, as we kind of talked about earlier, we're going to be looking at the size and the shape of the head. We're going to be palpating the fontanelles, which should feel soft and flat. We're going to be inspecting the spacing of the eyes and any asymmetry of facial features. And again, assessing head lag and head control at each one of those scheduled intervals for well visits. For the neck, we're going to be looking for extra skin folds, and then we're going to be palpating for any lymph nodes. For upper extremities and lower extremities, we'll be looking for muscle tone. We're going to be counting the number of digits. We're going to be noting the color of the skin and the nail bed, and looking for any evidence of genetic diseases such as Palmer-Creese. Now with the lower extremities, we're also going to be checking their hips with the Ortolani and Barlow maneuvers. And there's great videos on YouTube, so we don't have to repeat that here. For the spine and rectum, obviously we want to be assessing them for any malformations, such as a myelomeningocele. So at the base of their spine, we'll be looking for lesions, rashes, dimples, or tufts of hair. And then genitalia, of course, that's important as well. We want to inspect the diaper area for hygiene and rashes, and we also want to look and make sure the external genitalia looks normal. For a neuromuscular assessment, we're going to be looking at their level of activity, noting their muscle tone and movements. We're going to look for those primitive reflexes and also look for them to go away at the correct ages. For eyes, we're going to be looking for drainage and nystagmus. Many infants are born with congenital tear duct obstructions. For the ears, you'd be surprised how much you can tell about the infant and their genetics from just looking at the pinna. We'll also be looking for skin tags, and you'll be looking to see, does the level of the ears match where they should be. For the nose, you'll be looking for patency of the nares. For mouth and throat, we're looking for any sort of abnormalities such as natal teeth, cleft lip or palate, or both, and also looking for normal reflexes such as the rooting reflex. And anytime you conclude the assessment, you want to discuss your findings, in this case, with the parent or caregivers, and then make sure you document everything appropriately. Thank you, and please continue on to part 3 of the video series in which we talk about the toddler.